Evening, everyone. This is Andy Gray from the University of KwaZulu-Natal, and it is my pleasure to welcome you tonight to this webinar entitled Pharmacy Against COVID-19. This webinar is brought to you by the International Pharmaceutical Federation, FIP, the Independent Community Pharmacists Association of South Africa, the ICPA, and is sponsored by AstraZeneca. So the numbers are still climbing. We have just about hit 500 participants, which I think is a fantastic turnout of African pharmacists tonight. So if I can ask the host to take us to the next slide. As I mentioned, this is sponsored by AstraZeneca, and I'm going to ask Barbara Nell if she can give us some quick words from the sponsors. Barbara is country president for AstraZeneca Pharmaceuticals of their African cluster. Barbara.
Thank you very much, Andy, and thank you very much for this opportunity. I think in these unprecedented times that we are currently in, I think the ability to have sessions like tonight where we can all collaborate, where we can listen and learn together is so important. And I think what makes me particularly excited about this evening session is the fact that we have definitely seen over the last couple of years how important the role of the pharmacy and pharmacists are. But I think even more so at the moment during the period of COVID-19. And just to briefly outline, for us at AstraZeneca, science and what science can do is very close to our hearts. And these are just some of the scientific advancements that we are currently working on as a pharmaceutical company. We are very heavily involved in monoclonal antibody research, where we're looking at various partnerships with academia, governments, biotech companies. We are also looking at investigating potential treatments. And here we are particularly looking at some of our current established medications, one in diabetes, looking at the prevention of organ failure, and then also one of our hematological medications, and to see whether this is when the patients get into that phase of developing the cytokine storm, whether that has a sort of a suppressive effect there to then reduce time on ventilation, and eventually have an impact on mortality. We are also looking at diagnostic development where we actually in collaboration with GSK, the Cambridge University, and the UK government to boost testing capabilities. If we move to the next slide. At the moment, we're also looking at the work that we are doing with the University of Oxford in terms of the development and the distribution of a potential vaccine. Many of you might have seen just earlier this week where actually the collaboration with Oxford University and Wits University was announced for 2,000 patients to be trialed on this vaccine. So the focus on the vaccine to prevent COVID-19 infection, we're currently looking at, the preclinical studies that has shown a strong immune response from one dose. We are currently looking at the phase 1 data end May, the late stage trials sort of by mid-2020. And then, really the key piece around complements and building on the existing scientific efforts to combat COVID-19. I think the key role that AstraZeneca has played in this partnership with Oxford is to establish the supply chain. In the end of the day, we're going to hope that if we have vaccines that are successful, that it's not just one, because we'll probably need 5, 6, 7 to really supply globally. But for us, the key thing as at AstraZeneca, and what is for me very important from an African perspective as well, is the equitable access to the vaccine. And I think this is also where the partnerships with Gavi and CEPI is so important for us to ensure the equitable access also to the low and middle income countries. At the moment, we need to follow the science. We need to wait to see what the studies show. But, once again, the involvement from AstraZeneca is very much there and the commitment is there. And with that, I'm going to hand over to Nilan Usman for the introduction to the FIP. Thank you very much.
Thank you, Barbara. Next slide. So I'm actually going to be doing that. For those of you who don't know the International Pharmaceutical Federation, or FIP, next slide. FIP is an organization, a global federation of national associations representing pharmacists, pharmaceutical scientists, and pharmacy educators around the world. It was founded in 1912, is based in The Hague in the Netherlands, and is a non-governmental organization in official relations with the World Health Organization since its very inception in 1948. Next slide. FIP is a leader of pharmacy at the global level. Its vision is a world where everyone benefits from access to safe, effective, quality and affordable medicines and pharmaceutical care. And so its mission is to improve global health by supporting the advancement of pharmaceutical practice, sciences and education. And it does that by collaborating with its members and its partners to maximize the global influence and contributions to healthcare of pharmacy, striving for the outcomes described in their strategic plan. So please visit fip.org to learn more about the Federation and perhaps to join as an individual member. Next slide. So our second co-host today is the Independent Community Pharmacists Association of South Africa. Next slide. ICPA represents more than 1,100 independent community pharmacies across the South African landscape. It involves 3,500 pharmacists and 20,000 support personnel. Pharmacy in South Africa is well developed, and this is a very important part of our landscape. Thank you. Next slide. Next slide, please. Okay, so I'm going to go into the presentations. The way we're going to arrange the webinar this evening is that there will be 6 presentations, one after the other, each of about 10 minutes. I will introduce each of the speakers and they will then present. And at the end of that, we will go to a panel discussion together with all of the panelists. And after that, we will take questions that you can input as participants in the Q&A sessions. The learning objectives for this webinar this evening are to provide you with an overview of the current situation of the COVID-19 pandemic and some predictions for the upcoming period, but to really focus, secondly, on pharmacists' roles and contribution in the COVID-19 pandemic, and to give you inputs from particular countries and the insights from what they are doing in those countries. We want to focus on the challenges and the difficulties faced by pharmacists, the expectations that they have, and how we might be able to support this important part of our pandemic response. So our first speaker this evening is Khatija Jamaluddin, who is Director of Affordable Medicines for the National Department of Health here in South Africa. Khatija is, in essence, the Chief Pharmacist of South Africa. Khatija, over to you.
Thank you, Andy. And thank you to everyone who made the time to join this webinar. Can I have my first slide, please? And the next one. Okay, so we are going to cover the topics as Andy has said. In my particular presentation, I've got the current situation of COVID-19 pandemic in South Africa, what we think the upcoming period would look like, what our pharmacists have been doing and our contribution towards managing the pandemic, the particular challenges that we face, what more is expected, obviously, because we're such high performers as a profession, and how we have responded to supporting our profession. Can I have the next slide, please? Okay, so this slide depicts I think the upsurge in patient numbers in terms of the COVID-19 pandemic. At the start of the pandemic, of the lockdown in South Africa rather, you would see that the patient numbers were very minimal, and suddenly we are seeing this, what they call the surge going up. Unfortunately, those numbers are a bit old because the slides were prepared 2 days ago in preparation for this meeting. And in terms of the fatalities, we've already exceeded 2,000 patients who have succumbed to the infection. In terms of active patients, we've already gone over 56,000 cases. The total tests, we are sitting currently on 1.5 million, and new cases yesterday was 5,688. I see that I should speak up. I hope everybody can hear me. Okay, next slide, please. So for predicting the upcoming patient numbers that we are likely to see as we move towards the peak, and talking about epi models, etc., I think we all are now familiar with what's known as the famous R, which is a transmittability rate. And this kind of predicts what we think we are likely to see in terms of proportions of patients that we are likely to see and how they would present, whether there would be severe cases, non-severe cases, how many severe cases are likely to end up in hospital, and those that end up in hospital, how many are likely to end up in ICU. And using that model, we've attached it to the patient numbers and also our population numbers to try and predict how many patients we are likely to see in hospital, where particular the medicines that they would need needs to be available. Next slide, please. So just in terms of the predictions, we, I think these epi modeling people have converted us. We now know about a pessimistic scenario and an optimistic scenario. So in South Africa, we are experiencing both. We have two provinces who are following the trajectory of the pessimistic scenario, that curve, which is the green line. So the solid green line will tell you the number of patients in hospital, and the dotted line will tell you the number of patients who are likely to end up in ICU. And our two provinces are the Western Cape and the Eastern Cape that's following that particular trajectory. And then we have the optimistic scenario, and the rest of the provinces are following that. And initially there was the skepticism, are we going to see these patient numbers? Are we likely to see an increase in bed occupancy or ICU occupancy? And for many facilities, the reports that we are receiving is that yes, clinicians are beginning to be run off their feet. There are facilities that have been overextended, and alternative facilities have to be found for them. So some wards have been converted into high care facilities, etc. So it's very real for us now in South Africa. Next slide, please. So in terms of the pharmacist's role and contribution in COVID-19, I can safely say that in South Africa, we've played an integral role at every level. So whether it was the development of evidence-based treatment guidelines and also the essential medicines list. So we had a number of rapid reviews that were undertaken in terms of the treatment modalities that are out there. There is a tendency to have a knee-jerk reaction when something is shared in the media about its efficacy, for example, chloroquine, and we have opted to take the safe route and rather follow an evidence-based approach to that. What we had also done at the start of the pandemic was to identify those medicines that would be particularly needed in the management of COVID-19. And what we had done is created a priority list, which is a subset of our master health product list, which we paid particular attention to, and to make sure that we had enough medicines of those particular medicines to manage our patients when they do present in hospital for either high care or ICU. Then preparing the supply chain to maintain a consistent and reliable supply of all essential medicines, because especially in this particular time, people are feeling very, very vulnerable and nobody can be neglected. And in this area, contract management becomes very important.
Yes.
Okay, so I've given you permission now.
So our contract management unit has been very active and integral in this. And our suppliers have also in general come to the party, and we can say that, as far as medicine availability is concerned, we are not doing too badly. The sourcing and procuring of sufficient medicine to meet the expected demand. Obviously, our contracted suppliers are not always able to meet the demand because it's out of contract, but alternative sources have been found. We have been able to get alternative suppliers and sometimes even alternative products where the medicine wasn't available. In terms of rational medicine use and antimicrobial stewardship, we have implemented a number of activities in this regard, and especially during this critical period where there's a tendency to treat a virus with antibiotics, we need to be very vigilant about how we are using our antibiotics. Not only in terms of the stewardship, but also in terms of the capacity and the demand for that. And then the crux of why we are here is the provision of patient care. And we want to make sure that our patients receive the medicines that they need, you know, wherever they are from qualified professionals. And to support all of this, there have been a number of legislative amendments which we've undertaken in South Africa, the chief among which is the extension of the validity of prescriptions during this period so that patients need not necessarily present at a facility for script renewal when they can get medicine repeat. And all of these activities, I'm happy to say we've been part of multidisciplinary teams, whether it's clinical teams, whether it's demand planning, supply chain kind of teams, legislative regulatory teams, etc. And you know, no man is an island, and we have to be part of that team that manages this. And I think it's that team spirit and that teamwork and that ability to work in a team that has given us the success that we are currently seeing. Next slide, please. So in terms of human resources, there are a number of challenges we face over and above the usual challenges that we do face. I think the big wake-up call was when the staff tested positive for COVID-19 at one of our major academic hospitals. And we were in a fortunate position to be able to provide some support to them in terms of employee wellness. And happily, the colleagues have come through that. What is more concerning is the resource constraints, because what we are doing is we are establishing field hospitals, for example, and you know, you only have a fixed number of resources, and to stretch that to more facilities becomes a big challenge. Then in terms of the demand forecasting, because we're following the epidemiological models, those models are reviewed on a regular basis, and as a consequence, our demand plan then also is reviewed and follows that pattern. And because the model is changing, we have fluctuating demand. Then the other challenge that we have to face is constraining the demand based on the hospital bed capacity. Because I think the reality is that we're not going to have enough beds to cater for all the patients that we are likely to see if we have to believe the models. And then the other challenge that we have is a significant increase in demand of medicines used in the management of COVID-19, outstripping supplier capacity. And I think, you know, that is a very big challenge for us because, as I said, there's a demand forecast which is fluctuating, and you need to, from a supplier perspective, they need to make some commitments, which is then difficult to make when you have to roll back some of the demands as well. Can we go to the next slide, please? Okay, then further challenges that we face is the supply, in terms of supply planning, where the supplier constraints are on some of the medicines. For us in South Africa, a big challenge is the inadequate storage capacity at health facilities, because at the start of the COVID-19 pandemic, Minister had given us a directive to say that we have to stockpile some of the medicines, and it becomes very difficult when you don't have the space to store the medicine. Coupled with that is the risk of overstocking, where you have excess stock, and because of the uncertainty, you know, there is a risk that this medicine will have to be written off in the case of expiry, for example. We also were very challenged in terms of, you know, we had the priority list. We went full steam ahead looking after the priority list, and the risk was that we would neglect the other medicines that were not on the priority list. And it goes to the constraints that we have in terms of time and the number of people to be able to do the work. For us, from a public sector perspective, another challenge has been the budget and the cash flow. So the way it works is you get a tranche of money being released from the treasury at certain points in time. And if you're going to do stockpiling, you need that money up front. You can't wait for the cash to be made available. So that was something that we had to work with provinces and with treasuries to try and resolve. In terms of the promotion of rational medicine use and antimicrobial stewardship, this is another challenge, because while we understand You know, the need to be very cautious about how we use medicines, especially antibiotics. When you, the prescriber at the coalface faced with a patient, you know, the decision becomes very difficult. And we have implemented a number of interventions with our provincial counterparts to try and see how we manage the situation in terms of stewardships, etc. And then changes in the clinical guidelines for COVID-19 management as it impacts on the demand plan. So for example, in the case of chloroquine, we were lucky we did not include it in the guidelines, but in terms of the steroid uses, we had gone for most of the steroids, but when the data came out to support dexamethasone, a number of guideline changes had to be made to support that. So those are the challenges we faced. Next slide, please. So because we're such high performers, I think in every part of the world, pharmacists have a number of characteristics: the commitment, the courage, the consistent excellence and teamwork that we exhibit makes us prime targets for people to give us more responsibilities all the time. So in our setting, we have now added responsibility of managing PPEs and other medical consumables. And I must admit that I know very little about these things, but because there's a need and because we don't want patients to be disadvantaged, we take on the task that is assigned to us. The unintended consequence of this is that additional strain is placed on already constrained resources. And I think everybody would agree that that is a risk that we will particularly face, especially as the disease progresses. Next slide, please. And how have we responded? So at the start of the pandemic, or start of the lockdown rather in South Africa, we had already established a governance system where we tried to bring order in the chaos instead of running along like headless chickens. We had a plan. We had consultative sessions with our provincial counterparts. We made plans together. We listened to what the challenges were, and we implemented a remedial action wherever necessary. And that was always in consultation with what we are hearing on the ground, trying to respond to all of that. And that wouldn't have been possible without the governance system that we had put in place. We also felt that the fact that we had a number of tools at our disposal to help us to make effective evidence-based decisions, such as our National Surveillance Center, where we have end-to-end visibility of the supply chain in the public sector. This gave the colleagues on the ground some power to be able to make many decisions that will help make sure that medicine is available. Additionally, the publication of guidelines, the rapid reviews, etc., where it was made publicly available, has also assisted in managing a lot of the expectations on the ground. And especially in the situation where there were reports that BCG was being used to manage COVID or to prevent COVID-19 infections. And, you know, people being our greatest resource, we can do a lot of fancy footwork, but our people are our greatest resource. And without our people, we won't be able to achieve what we have achieved. And we've embarked on a change management program in South Africa, where we try to make sure that people know what we are doing. People feel supported, especially in the provinces, especially those pharmacists at the coalface, because it's easy for us as policymakers to sit in our office, think up stuff, and be very fancy about things. But it is the people who are facing the patients who are actually providing the care that need our support. And we have tried to provide that in the form of the change management program that we have. And that in a nutshell is what we have been doing in South Africa. Thank you very much.
Thank you very much, Khatija. Thank you for that very concise but wide-ranging presentation. I need to remind everyone that this is being recorded. So know that all of the presentations are going to be recorded, and you'll be able to review this webinar from the sponsoring organization's websites. So can I have the next slide, please? So our next speaker is Dr. Jean-Baptiste Nikiema. Jean-Baptiste is the Technical Officer for Medicine Supplies and Health Technologies at the WHO Afro office in Brazzaville, in Congo, Brazzaville. And Jean-Baptiste will not be using slides, so this slide will stay, but I invite him now to tell us about what makes Africa different and how WHO is supporting the COVID pandemic response across the continent. Thank you, Jean-Baptiste.
Thank you very much. Good evening, everybody. On behalf of WHO, I would like to thank FIP for the invitation to participate in this important call. This is highly appreciated. Let me start by a short overview on the epidemiological situation related to COVID. Globally, we are approaching the 10 million cases in the world, and the number of cases in the WHO African region is now approximately 200,040 cases in the region. This was the situation yesterday. Maybe it's, as the situation is evolving very fast, it should be a bit different today. The number of deaths is approaching now 5,000 deaths. South Africa, Nigeria, Ghana, Algeria, and Cameroon are the most affected countries in the region, but many other countries are also experiencing community transmission. There is a fast evolving pandemic situation in many countries. For instance, the doubling time in days is about only 10 days for the entire region, with some disparities between countries. There is no proven evidence on what makes Africa different regarding the number of cases, which remain a bit low compared to the other WHO region in the world. And maybe the fact that Africa is learning a lot from other experiences. You know, the disease, the outbreak started in China, and after that, Europe, America. So we are learning from their experience. Therefore, we are prioritizing in our region investment on prevention in the context of weak health system, particularly for intensive care to be, all those things need to be documented. Probably they are contributing to explain the low number of cases in our region. But we need to keep vigilant and maintain the effort in terms of social distanciation, in terms of other measures for prevention. As you know, there is no pharmacological cure until now. And WHO welcomed the initial clinical trial result from UK that showed dexamethasone, a corticosteroid that can be life-saving for patients who are critical ill with COVID-19. This is a very, very important development, and it's important to mention that because it's the first time that we are seeing clearly something that can help to save lives. For patients on ventilators, the treatment was shown to reduce mortality by about 1/3. This is particularly important. The benefit was only seen in patients seriously ill with COVID-19 and was not observed in patients with milder diseases. This is also important to notice. From WHO point of view, is important not to restrict the role of pharmacists to just dispensing essential medicine in pharmacies. The pharmacist is the public health leader, particularly in the African context, where pharmacists have an important role to play in health care more than just selling medicine at pharmacies. Integral part in the healthcare team and assumes varied functions to ensure the best treatment for patients. The pharmaceutical care processes involve establishing a relationship between developing an evidence-based care plan for medicine therapy and follow-up of patient expected health outcome is critical. The role of pharmacists is also critical along the pharmaceutical chain, starting from research and development to the use. For instance, in the African region, many pharmacists are involved in on research on traditional medicine and clinical trial, for instance. Pharmacists are also involved in the overall governance of the health sector, policy formulations, selection of essential medicine, procurement and supply management, regulation, dispatching, pharmacovigilance, and pharmaceutical information. The pharmacist highly contributes to achievement of health goal in our region. Unfortunately, the data on pharmacy workforce is a bit, we are a bit weak on that. It's difficult to get data in the African region. Just to recall that the World Health Assembly resolution 6919 urged member states to consolidate a core set of human resources for health data with annual reporting to the Global Health Observatory, as well as progressive implementation of national health workforce accounts to support national policy and planning. I take this opportunity regularly updating the health workforce data in the WHO observatory. This is much appreciated. I will share the link to access the observatory in the chat soon. There is clearly a shortage of pharmacists in the African region. The density of pharmacists in the WHO African region ranges from 0.01 to 4.4 pharmacists per 10,000 population. The median density for the region is less than 1 pharmacist per 10,000 population, where the standards recommend. So we are far from the standards. The low-income countries have about 10 times less the number of pharmacists per 10,000 population than the medium and high-income countries. We can see it, this disparity also in the African region. It's evident that there is a critical shortage of pharmacy workforce in countries, and this therefore necessitates to develop some strategy to change definitely the situation, because the shortage is making a lot of problem in terms of pharmaceutical system development in our region. Due to the shortage of pharmacists, specifically in developing countries, pharmacy technicians are playing a greater role in delivering pharmaceutical care in countries, and we need to recognize that. In some countries, there is greater emphasis on the production of pharmacy technicians, while in some others, the situation is a bit different. In the African region, pharmacists are operating in the context of weak regulatory system, low local manufacturing capacities, high risk of substandard and falsified products, and the global shortage of COVID-19 commodities such as PPAs and diagnostics. In our region, have attained regulatory system maturity level 3. Most of the countries are at maturity level 1, indicating that in these two countries, the system is well functioning and integrates all required elements to guarantee a stable performance. This is a way we need definitely to work on to make the difference. Africa is 70% dependent of imported pharmaceuticals. Reliance on the medical product importation is rather higher in the region and can even exceed 90% in some countries. In the context of COVID-19, many countries have put in place export restriction on priority medicines such as paracetamol, antibiotics, antivirals, contraceptives, thus potentially create tension and stock out on on both public and private side distribution channels in the African region. WHO also issued alert on falsified HIV HIV rapid test diagnostics circulating in the region, and also products circulating particularly in West and Central Africa in the particular context where at a certain moment chloroquine were promoted to be used for the treatment of COVID-19. There is no way for one country to have success alone and silos. A partnership is a key, and African leaders understand very well this fact. This is the reason why they are pushing now seriously for the establishment of the African Medicine Agency, and also for local manufacturing through joint initiatives and also pool procurement. From WHO, what we are doing now in this particularly context, we are making sure that clear provided to countries for the management of COVID, particularly to prioritize the protection of healthcare professionals, including the pharmacists. We are also implementing an accelerator tool to accelerate development availability of a new COVID-19 consolidated package of tools to be used in countries to accelerate access to quality, safe, effective, and affordable COVID-19 diagnostics, therapeutics, and vaccine. You can see that during the 2 days, yesterday and today, the African Union Commission, Africa CDC, and WHO are working, discussing with some head of states in the region about vaccine related to COVID-19. So this is taken at a very high level in the African region. Capacity building is also one of our area of support to countries, particularly for that we are collaborating with WHO collaborating centers, institutions in countries, and for instance, in South Africa and one in Algeria, working particularly in the area of quality assurance of medicine, and we are using them to train the other countries. Tool for forecasting the need and alternative option for supply chain are also being used to support countries. We are also promoting local manufacturing and pool procurement. For instance, the small island developing state, we are supporting them to implement a pool procurement program, particularly for essential medicine. To conclude, I would like to take this opportunity to congratulate all the pharmacists in the African region, because they are at the front line of this fight against COVID-19, and we need them. We need their work, their support to succeed in this important fight. We are calling for solidarity also among member states in the African region, because some countries are experiencing shortages of and stock out of essential medicines, and probably we may need to negotiate with neighboring countries to transfer some essential medicine to these countries to save the situation and help them while they are waiting for services to take some orders and take new medicine in the country. This is particularly critical for HIV medicine if we want to avoid the development of antimicrobial resistance that will be very serious in our region. Thank you once again for the opportunity, and I wish everybody a very good meeting. Thank you.
Thank you, Jean-Baptiste, for that very comprehensive description of what makes Africa different. I'm sure there are going to be questions from the participants. Just an update for those of you who have joined tonight. We are fast approaching 800 people on this webinar this evening. Next slide, please. So we're now going to move across the center of our continent. And we are going to ask Dr. Daniela Monwene, who is the CEO of the Pharmaceutical Society, not of Mauritius, but of Kenya, if she can share with us the experiences in Kenya of COVID-19 so far. Daniela?
Yes, please indicate that you can hear me clearly, please.
Perfectly.
Okay, all right, next slide, please. Right, so just the latest statistics, I think this was, I can put on my video. I think this was 2 days ago. Kenya had 4952 confirmed cases, 1782 recoveries, and 128 deaths. The epi modelers are telling us that the surge is expected in September. But I must say that our curve has not, the projections have been revised over and over and over again. And at the beginning of this pandemic, with our index case in early March, we thought that the peak was going to come a little bit sooner, but it's been a very slow rising peak, and we're still asking ourselves, what are the underlying factors why the rate of transmission is lower than expected. So now they're saying the peak is expected in September. We're getting ready for that. We're certainly thankful that it's not been as vicious as initially modeled. So we'll see. Right now, a new development in Kenya is that home-based isolation and care has been introduced. Interestingly, about 81% of the people that test positive have been asymptomatic. And so the policy that has been existing, that every positive case is put in an isolation ward, has started to burden our health facilities, because our isolation wards have been full of people who are not sick. And so this is very recent. In fact, last week, the government allowed home-based isolation and care for people who demonstrate that their living environment is conducive. And so as a pharmacy fraternity, we're expecting a little bit of change in health-seeking behavior of people who are in isolation, or their families that are taking care of them, when they're home. So we expect a little bit, maybe more demand for pharmacy deliveries and that kind of thing. We've also had reduced non-COVID hospital visits. That's something that we did not expect to experience on the scale that we're experiencing. But this has also meant an increase in demand for digital health services, including telepharmacy and home deliveries. And this then has made us relook at our regulations for digital health services, because these regulations have not been as far along developed as should be ideal. So this pandemic has certainly fast-tracked the regulators, the medical regulator, the pharmacy regulator, to look at regulating the online health space. And I think that's a good thing. Next slide, please. So I'll just touch on what we as pharmacists in Kenya have been contributing in responding to this pandemic. So a lot of our pharmacists in Kenya work in the distribution supply chain. And so we have a lot of supply chain experts, and they've participated in quantification and forecasting for the health products and commodities needed for the pandemic. And in terms of this quantification and forecasting, we have even developed, as the Pharmaceutical Society of Kenya, a list of essential HPTs for COVID-19. Not necessarily the therapies for treating the disease, but other, adjunctive things that you need to treat a patient. Whether it's a sedatives when you're putting the ventilator or when you're intubating. So we actually have developed as PSK, and this we share with our members and with the policymakers. In terms of infection prevention and control, our pharmacists have been participating in the hospital IPC teams. They've been participating in development and dissemination of guidelines, and some of them are even preparing hand sanitizers for their facilities. We have community pharmacists who are doing this. We have some pharmacists in hospital who are developing these hand sanitizers. In terms of case management, we've also created guidances. I would call them guidances, not really guidelines, for the drug management of COVID-19. So what we've noticed is that the global guidelines and the ones we get even from our own Ministry of Health, in the sections that talk about the medicines, there's no deep dive into the contraindications, the precautions, and the things to watch out for. So what we've been doing as a body of pharmacists in Kenya, under PSK, the professional society, we're looking at the guidelines, the national guidelines, and in the sections that touch on medicines, then we do a deep dive into, all those things, the contraindications, what to do with comorbidities and other concomitant drugs. And so we've been issuing a medication management guidance for all clinicians based on the national treatment guidelines. In terms of case management, again, our pharmacists who are working in the hospitals with the isolation wards are engaged in medication therapy management for the patients. One of the other big things that we're doing as a society is risk communication. So I'm sure myth busting has been an issue for all countries because of all the false information out there. And so risk communication, is also about educating the public. And so as PSK, we send out posters and, tools that our members in community practice, hospital practice, can use to educate their patients. They just need to print them and, put them around their pharmacy. And this has addressed a lot of issues. For instance, there was panic buying at the beginning of the pandemic. People were, asking for so many things from the pharmacy, some rational, some irrational. And so a lot of education was needed. Things to do with infection prevention and control, how to wear a mask. We're helping our pharmacists in the front line to educate their clients. Next slide, please. So a little bit about the challenges we've experienced. Like I mentioned, the epi curve has been completely unpredictable. So sometimes, at the beginning it sounded very dire, and then it was not translating to reality to an extent that couldn't really be explained by the restrictions, movement restrictions that were imposed. And so even demand forecasting becomes an issue. And because you don't want to overstock on things that you thought you needed and suddenly then you don't need. The other thing is unavailability of medicines and other health products and technologies. As Dr. Jean-Baptiste has said, Africa is really import dependent, and certainly in Kenya, 70% of our health products and technologies are imported. And so, when China was locked down, we experienced a lot of outages of a lot of essential products. And this comes along with price hikes. So whatever was left in the supply chain suddenly became so expensive. The other challenge we've had is over-the-counter demand for perceived preventative and curative medicines. For example, hydroxychloroquine sulfate. Like I said, some of the things that people demand at the pharmacy are completely irrational. We've seen people asking for this hydroxychloroquine, and it was quite a challenge, because normally, you know, it's not a very fast moving product because it doesn't have many indications. And so for people who are able to get from unregulated drug shops, you know, this actually depleted the supply for the people who actually need it. So we've had people overstocking on surgical masks, on thermometers. We had a lot of demand for chronic medicines, people stockpiling, a lot of demand for condoms. That was an interesting one, but I think it was because of you know, people being told to work from home. A lot of demand for sanitizers. Some people were coming to the community pharmacies to asking for nebulizers. Some people were buying oxygen concentrators. You know, you wonder how they were planning to treat their COVID at home with oxygen. And of course, recently there's been a rush for ivermectin and dexamethasone. Because obviously the message that, you know, some of these medicines are for severely critically ill patients does not communicate. People think they're going to treat their COVID at home with Dexa. But of course, there were some rational purchases like vitamin C supplements and zinc and the rest. There was a rush for that, inhalers, mouthwash. So that has been an interesting scenario. Now, in terms of the support that PSK is giving and pharmacists are giving to address these challenges, like I said earlier, we are issuing guidances to pharmacists on IPC and case management and risk communication as well. And these guidances are also to help other clinicians. And we have ramped up our communication avenues to our audiences, to our members and other healthcare professionals by way of CMEs and webinars. And this has really been useful and has, you know, in terms of experience sharing from different pharmacists working in different settings, these webinars have been extremely useful. So that's just a summary of what we're experiencing in Kenya. Over to you, Andy.
Thank you very much, Daniela. That brings us very neatly to the next speaker, if we can have the next slide. So we're now going to head not to the far west, but Ghanaians will tell you that they live at the middle of the world. They're on the Greenwich Meridian and just off of the equator. So they're at 0 and 0 latitude and longitude. Our speaker this evening is Ben Botwe, who's president of the Pharmaceutical Society of Ghana. Ben, the floor is yours. Ben, you just need to unmute. There you are.
Thank you. Thank you. Andy, I was just saying that you were invited to visit the center of the world. And to also thank AstraZeneca and FIP for this opportunity to share a few things that have happened and are continuing to happen in Ghana in terms of COVID-19. Next slide, please. Next slide. We will be talking briefly about the national efforts and strategy and also the pharmacists' involvement at the national level and the preclinical interventions and clinical interventions, and then we conclude. But let me quickly quote what our President Nana Akufo-Addo, has always been saying, and which has become very, very significant in terms of the fight against the COVID-19, that we know how to bring the economy back to life. What we do not know is how to bring people back to life. And that has been the focus for all the actions and attempts at national and institutional level to combat COVID in Ghana. Next slide, please. So the statistics, and I think it has changed over the last 2 days. This was recorded as of 23rd June. But as of today, the cases have gone up to 15,013. Recovery is at 11,078 and death is at 95. So this is the most current statistics. Government has a big approach with presidential COVID committee coordinated by the former deputy director of WHO, Dr. Asamoah, and also an interministerial committee that is set up to focus on COVID activities. Next slide, please. So this is a graphical presentation of how the trends have been since the first case was recorded in March. And well, the forecast is that we may be approaching the peak and maybe start plateauing. Next slide. So the government response and the whole national response has been based on 5 strategies: limit and stop importation of the cases, which worldwide travel restrictions have been undertaken, and people are not traveling across countries and so on. The next strategy is to detect and contain cases, and therefore social gatherings are restricted. Public institutions, particularly institutions of education, have been closed until recently, where final years and those writing exams have been permitted to go back. There is active tracking and contact tracing. People cases are quarantined, hotspots have been detected, and wearing masks in public is virtually compulsory as we speak today. Next slide, please. So the next strategy is to care for the sick, and therefore treatment centers have been set up across the country. There are isolation facilities, and I must say that there's home isolation as well. And then for frontline health workers, government has issued insurance packages and tax reliefs and so on. Then the other strategy is the reduced impact on social economic life. Government has an alleviation program. A COVID-19 fund has been set up. Government, up until June ending, we don't know whether it will be extended, is absorbing all water bills and rebates for electricity bills for different types of communities, and also for manufacturing and local production. And finally, the domestic capability and self-dependence and self-reliance. So companies are encouraged to do local production of PPEs using local fabrics and so on. Local manufacturers of medicines have also been encouraged. There is the strategy to set up possibly a Ghana a CDC and infectious diseases center, and also strengthen the research. This is in line with government policy of Ghana Beyond Aid. Next slide, please. So a lot of strategies have gone on. Government responses, the multi-sectoral ministerial team, multi-sector laboratory networks have been made. And there is also a major strategy of using drones to deliver samples to testing centers. And I must say that the gentleman managing this whole zipline drone system in Ghana is a Ghanaian pharmacist, and we are very, very proud of him. Some university scientists from University of Ghana have tried to sequence, and they have, the COVID-19 virus, and that is in the international literature. Some department in Kwame Nkrumah University of Science and Technology has also come up with rapid diagnosis tests, which is still in the testing phase. And there are enhanced testing strategies. Guidelines have been issued for test kits, and then also isolation facilities have been provided by churches and other private organizations. Private sector is manufacturing sanitizers alongside PPEs, and the Food and Drugs Authority and Standards Authority are coming up with standards and also enforcement strategies and to facilitate the whole process. Next slide. So pharmacists' involvement, and I must say that at the national level, pharmacists have been working with the National COVID Committee, the whole National COVID committee, and then also subcommittees for COVID commodities, where pharmacists are working on. Pharmacists have been involved in the development of the COVID treatment protocols and guidelines, that is going on. And as a social responsibility, Pharmaceutical Society also issued guidelines for community pharmacy practice to protect themselves, their staff, and their patients in this COVID era. And as a social responsibility, the Pharmaceutical Society contributed 100,000 Ghana cedis, equivalent of close to 21,000 US dollars to the National COVID Trust Fund. So that is the president presenting the dummy check to the chairperson of the National Committee. Next slide, please. So a number of guidelines, you may not see them very well, but a number of guidelines and animations have been done and distributed to pharmacists. We have collaborated with the Ghanaian Pharmacists Association in the United States to work on some of these things. And they are being used all over in public places, in pharmacies, and also in community pharmacies particularly. And can we go to the animation slide to just watch?
Wale namo adaficha the parables ke amekpelo ni Pharmaceutical Society of Ghana bi anwa bahanye. Bepomeno ni coronavirus no ichengo mowaji ke otara ohimbe ogugo ke onabuhi ke oniji ni hemu awa ne ekoyo ke hani osa coronavirus ke mwa ekokumana ye onija ifom gbejano to neno ke fo ohi afaban. Mo oden Kasamla agbe for odeng ni etwafu ngbe twanyuma enyo oyin akakpano ake oba for owabi aten ke owabi ana ke oniji ase ke okenu ni wo efoflo oniji ahe ngbe twanyuma mo odeng ni onganwe ewa akwala kaimo ake oyafa ban foji oti fo oyafa ban ye hewale papa na momle.
Yes, so next slide. You will not understand the language that is used, but we have done it in 5 different local languages, and that is the focus, and that is why I did not show you the English one, but just to let you understand that in order that it goes very far to all corners of the country, the 5 major languages in Ghana were used in these animation videos. To sensitize people. Apart from this, the society has issued a circular to all pharmacists and also educating them on what to use and the use of sanitizers and things like that in the pharmacy and in workplaces and things like that. Next slide, please. Yes, and also apart from the support to the general public, society has also organized a number of webinars using resources from across board, and one is even happening today at 7 p.m. With community pharmacy practice in the evolving COVID era, and that will be taking place at 7 p.m. Ghana time today, but we have had previous ones where speakers from clinical settings, from other society practice areas have spoken on the COVID as part of our educational program to pharmacists in general in the country. Shall we move on? Next slide. So in the clinical settings, pharmacists are directly involved in developing treatment protocols and ensuring the availability of timely and timely provision of safe and effective drug therapy. They are also providing drug information and advice in all the treatment centers, in the major teaching hospitals, regional hospitals, and other treatment centers that have been set up by government. They are taking medication history and patient monitoring as well, educating and counseling patients, identifying patients and their medication risks, and also detecting and reporting adverse drug reactions and events. And they are part of clinical teams. They go on ward rounds to look at patient drug and medication therapy. Next slide, please. These are some of the forms, examples of some of the forms that have been developed at the pharmacy departments of one of our major treatments at Accra Regional Hospital, and it was developed by and is handled by pharmacists, and it's formed part of patients' dossiers in the hospital, and that is a very significant development in clinical pharmacy practice in Ghana today. Next slide. So in the non-clinical, pharmacists are involved in public education on safety measures, ensuring that we have the right concentrations of disinfectants and antiseptics. And when it started and there was shortage and high cost of isopropyl alcohol, people were using a local brew, a local drink to prepare sanitizers. And the society and pharmacists had to embark on a major public education on that to dissuade people from using that, because we are not sure of the standards and the alcohol percentage that is in that. So, and rapid diagnosis testing for COVID-19 in community pharmacies are anticipated in the future as diagnosis testing, rapid diagnosis is evolving. And financial report on treatment given to patients at discharge to management. Pharmacists are involved in that, and then ensuring that there's rational use of PPEs together with their team members at the treatment centers. And the picture there shows you a clinical pharmacist who is about to enter a patient's ward, isolated ward, to have discussions with the patient on the medicines therapy at one of our treatment centers. Shall we move on? Next slide. So the society also undertook to visit some of the treatment centers and find out their needs for PPEs and so on. And these are the needs that have been identified. We have received support. Apart from what government is giving, the society has received support to procure some PPEs that will be distributed to these centers based on the risk, the needs assessment that was done in the coming week. Next slide, please. So, like I said, we have one webinar today at 7 p.m., Community Pharmacy Practice in the Evolving COVID Conversation. And we have keynote speakers, one of our colleagues practicing in the UK, another one practicing in Ghana, to share the perspectives on webinar today. Next slide, please. So, shall we roll this one?
As confirmed cases of COVID-19 continue to rise, it has become extremely important to adhere to the directive given by the health experts to wear face masks, especially when in public. The coronavirus is known to spread through person-to-person contact. Example, while speaking, sneezing, or coughing. The mask acts as a physical barrier to protect you and others from the viral particulates. Here are some few guidelines on the appropriate handling of face masks. Always remember, homemade masks should always be washed, sun-dried, and possibly ironed before wearing. Wash your hands with soap and water, or use an alcohol-based sanitizer before putting on the nose mask. It is important to have your mask on whenever stepping out of your home or you are being visited by someone, be it at home or at work. Do not touch your face mask or wear it below your nose or hang it around your neck. Do not eat or attach your phone to your ear to speak when your mask is on. To remove the mask, simply lose the end strings without touching the mask itself. Fold the used face mask, making sure the contaminated part faces inwards, and tie the ends together and wrap it in a plastic bag before depositing it in a waste bin. Wash hands right after or clean with an alcohol-based hand sanitizer. Reusable cloth masks should be washed in warm soapy water and dried in the sun. Remember, wearing a face mask means I care about you and me. Whilst at this, don't forget to continue to practice additional safety preventive measures like hand washing with soap and running water and social distancing. Together, we can win this fight against COVID-19. This message is brought to you by the Pharmaceutical Society of Ghana with funding from Novartis.
So that next slide, that brings us to the end, and I just want to say that a few challenges, not different from that, what is happening in Kenya when there is some prices of commodities have gone up because of COVID, and then demand on unreasonable and irrational demand for certain commodities, particularly this time dexamethasone, chloroquine, and hydroxychloroquine, and others. So thank you very much, and enjoy the rest of the webinar.
Thank you, Ben. We're now going to move completely off the continent, but still within the African region. And our next speaker is Nuveen Jagesa, who is president of the Pharmaceutical Association of Mauritius. Nuveen has a background in many areas of pharmacy, and I'm sure that he will be able to give us a very comprehensive look at the experience on the island. Thank you, Nuveen.
Thank you, Andy. Good evening, everybody. Can you hear me? So, first of all, it's an absolute pleasure to be here and present to you an overview of Mauritius. Well, to start with, we're a small region, so we were lucky enough, thanks to the good initiative by the government. Please, can you play the slide at the same time? Yes, the next one. The following one. Next slide, Andy, please. Yep, perfect. So coming to what I was telling you, it's, we were lucky enough, thanks to the initiative taken by the government, to go on the lockdown mode at the start, let's put it mid-March, somewhere around mid-March. So in the initial, we had a few cases identified in Mauritius, and the government reacted promptly to the situation. And this was done by contact tracing. So those who were infected were isolated, they were quarantined. And in Mauritius, we had 2 hospitals who were converted just for the COVID, converted as COVID hospital. So being a small region, like I said earlier, it was easier for us to control it. So with everybody on an isolated mode, with a lockdown, nobody moving out for the first phase of the lockdown, as I would put it. So nobody had to move out for the first 15 days. Everybody was confined home. So that was quite helpful in preventing the spread of the virus. And after that came the second wave of the lockdown, where people were allowed to move, but we were allowed to move in a systematic way. Like people were allowed to move for shopping and so on. That was done technically on an alphabetical order. So that helped us pretty well. And since the 13th of June, we've taken out, we are no longer in a lockdown mode. So it's been lifted now. So that really helped us. And as you can see from the statistics, we had 339 cases of COVID in Mauritius. And I just had a few updates. My friend just sent me on an SMS. So I would like to update the slide at the same time. So the number of active cases we're having are 3 cases. Unfortunately, we had 10 deaths in Mauritius, and the number of people who recovered, it's 326. I would say we are already COVID-free, but the 3 cases would be people, or I would put it that way, like colleagues who are natives who've been repatriated to Mauritius. So once they land at the airport and they are detected positive, they've been sent to quarantine area, and they'll be monitored there from there onwards. So we had no PCR, number of PCR tests conducted, 30,347. And the number of rapid antigen tests done for COVID-19 is 96,586. And the number is still rolling on because we are expanding it to our frontliners and all. Next slide, please, Andy. So what was the role of the pharmacists and their contribution during the pandemic? Like I said, it's a small region, so it was quite easy to handle it. But we pharmacists did play a big role, a huge role in it. The first one, like most of our colleagues in the region, from what I've heard, we've been here to spread an awareness among the population, our patient, on how to cough or sneeze, how to wear a mask, how to wash hands, all the basic sanitary hygiene condition as recommended by the WHO. So we had to coach our staff on how to protect themselves and how to manage the patient entering the pharmacy premises. We had to ensure the safety of our staff and patient at the same time, those visiting the premises. While most of the doctors, we had noted that particularly in Mauritius during the time of lockdown, most of the doctors were not operating, so they were mostly isolated at their own at their home. So what happened, like all the patients who needed medication, they always or counsel, advice, they turned to us pharmacists. So as frontliners, we really had a supporting role in helping them. Then we also had to develop an emergency plan on how to tackle it if we had a suspected case. Unfortunately, from the government, we didn't have any support on that part, but we had colleagues who've been supporting each one another in developing the plan. Like for instance, at the level of the association, we tried to tailor-make the WHO guideline to our local needs. We had some other colleagues also who tried to design something more or less similar. And we tried to merge it up and present it to the population of pharmacists on how to handle it. And then we believe, we as pharmacists, we felt that we needed to help the government in its endeavor to limit people's movement, because if we isolated, that was the best way to tackle the issue. So we encourage people to move to optimize on technology, I would put it that way. So people started placing their orders for pharmacy on using apps like WhatsApp. And then we had those people, when they had to collect their medication, they didn't have to come anytime during the day and queue up. So they had to come at a specific time. We would call them. Some of our colleagues also went out of the way to deliver the medicines, especially for people who would have been like geriatric patients, pregnant ladies, or cardiac patient, high-risk patient, I would put it that way also. And we had to also ensure that we had free COVID tests to be done. Like the government came with a policy, like for government officials, they were going to do it, but we'd been having a discussion. I would put discussion with them, and finally, it was agreed that even the frontliners in private, we would be having the free COVID tests. So that's how we contributed in our way. Andy, please, could you please change the slide? Thank you. You're missing one more slide. There's one slide you miss, Andy, the challenges.
Sure, what's happened, perhaps you can just speak to that. Naveen, sorry about that.
Okay, that's fine then. So actually, what are the challenges we face in Mauritius? It was mainly like, it's a sad picture, I would put it that way. We pharmacists always the last people to be recognized, or we do not get any appreciation or recognition by our policymakers. So whatever was prompted in the medical field, it was mainly for the nurses and doctors, not even the pharmacists. It was really sad, but we tried to find our ways through. And to allow the frontliners to move, we had a work access permit. So it was announced in the initial that frontliners would be exempted, but we pharmacists were not put in the list. So it was only quoted somewhere, but nobody really put pressure, or nobody really enlisted us on that list. So what happened, many of our colleagues who tried to move out during the confinement period to go to open their pharmacy to help their respective communities. Some of them were fined, some of them were upon request by the police officers, they had to go back to their home, and they couldn't open their chemist shop and all. Another point we really have faced problem was the security of our staff and of pharmacies, because we had one isolated case where pharmacists were verbally and almost physically manhandled by a frustrated customer who got fed up waiting in the queue and the mask on. We know how inconvenient it is. And the distancing protocol also, he wasn't following up. So when the colleague pharmacist tried to bring him to order, he got annoyed and tried to physically handle him, but luckily he could get out of it. One of the key issues we had was the risk of out of stock of supply of drugs, especially in Mauritius, since the pharma sector, we are importers and we don't have any local manufacturing units. So a great note of appreciation to our colleague wholesalers and distributors who manage somehow to get the products on the market and avoid a risk of out of stock. I would also put it that we had the public who started. We had the problem on the public mainly because public. What happened when the people used to make an excuse. We was the only place where you wouldn't need any special permission to move. So anybody who wanted to go out just to break from that monotony of being confined, they would say, "I'm going to the pharmacy." And we've noticed people coming buying one paracetamol, one strip of paracetamol, and then later in the afternoon he'll come back and buy a couple of other medicine like that. But we try to reason the people. Some of them complied. Some of them finally we had to push them away somehow. And also the problem during the lockdown, we had a specific time to operate, which was Monday to Saturday from 9 to 2. And on Sunday public holidays, we were supposed to be shut down. So whatever happened in case of whenever there was an emergency, people they were referred to private clinics. They were scared to go to the government hospital because mainly most of the cases were being tackled there. But in some cases, I would say, great thanks to some of our colleagues, they would go on those odd timing, open their pharmacies and serve their patients. Thank you. That's all for me from Mauritius. Thank you, Andy.
Thank you, Naveen. Thank you very much. And apologies for that slip with the slide at the end. So as you can see, our last speaker this evening is going to give us an African perspective, but from the pharmacist perspective, not from WHO. Jocelyn Chaibva is Vice President of the African Pharmaceutical Forum of FIP and is based in Zimbabwe. So Jocelyn, over to you.
Thank you, Andy. You can hear me?
We can, perfectly.
Oh, thank you. Next slide, please. Can I have the next slide? Thank you. For my presentation, we're going to be talking about the pharmacist experiences. And I'll just say that's the presentation outline, overview of the current situation, pharmacist perspective, Zimbabwe and other APF member countries, pharmacists at the front line, what is our contribution, challenges and difficulties faced by pharmacists, expectations for supporting pharmacists, and a conclusion. Next slide, please. All right, current overview. I think we've all heard from the WHO representative. Africa so far has the lowest infection and death rates. Of course, there are high rates in South Africa, Nigeria, as stated earlier on by the presenters from those various countries. The thing is, we've had presentations from the various countries which looks at African perspective, what is happening in different countries. As I go through, I'll just chip in one or two things from Zimbabwe perspective, just to also highlight as a member of the African Pharmaceutical Forum. So when I talk about generally in Africa, there's been a very low infection rates and death rates compared to Europe and other countries. But as pharmacists and as Africa, we must try to preserve the advantage. So I will talk a lot about prevention is cheaper than cure. We often talk about better than, but I think when you look at management of cases, it's cheaper than cure. The cost of medicines is better reduced if people do prevent transmission of the infections. So you find that there's the lockdown. Unfortunately, it's not standard for the various countries, and there's no coordination per se for the various countries. So and the border controls are dependent on political agenda and not necessarily on the health agenda. So you find that across countries, an example which comes to mind is Kenya were the first to close their borders, but their neighbor in East Africa, they did not close the borders. So you find that the transmission or import or export of the infections can become a challenge for the various countries. Then currently, there's no proven treatment. There have been clinical trials for hydroxychloroquine and chloroquine. One day they say it's working, the next day it's not. So the clinical trials are still ongoing. And the guidelines is for the use of hydroxychloroquine and chloroquine under clinical trial conditions. As someone mentioned earlier on, there's been a demand from the public when they hear about these drugs. Chloroquine was used commonly for malaria in Zimbabwe and other countries, and it's no longer a first-line treatment in malaria. But now with the COVID, there's an increase in demand. And this brings a challenge when they're in public, there's that the product is going to be used and it's effective and so on. Because for the pharmacists, in various levels of the supply chain, be it manufacturers, wholesalers, and community pharmacists, you find that you are being pushed to try and bring this product on the market because the word is going around that it works, and yet it's only being used in clinical trials. And one of the manufacturers, our sponsor, they were talking about vaccines. As we know, there's no vaccine yet, but we hope something will come up and we can move to prevent the infection, which still brings me back to prevention being cheaper than cure. Because when you look at someone, case management in terms of antibiotics, hospitalization, the cost is very high. But if we manage to prevent the transmission, it actually works very well for us. And it helps us as Africa and any other countries to maintain costs. We're developing countries and we don't have resources that much, which we can spare for treatment. So if we can prevent, we're better off. And generally, that's, I meant there's no cure and we need to prevent. Next slide, please. Pharmacists' roles at the front line. We've been saying pharmacists at the front line. Community pharmacists are primary healthcare professionals. So you find that people just walk in, whether they are well or they are sick. They just walk in, no appointment, and the chances of bringing in infections are also quite high. So as community pharmacists, we have a role to play. And that also goes back to other members of the supply chain in the pharmaceutical supply chain, such as wholesalers and manufacturers, because the demand which comes to community pharmacists is will fall back on the supply chain. So as community pharmacists, we find that we need to be involved in a basic temperature screening, which is for customers and for our staff, so that we do not have transmission of the infection, which can be from the staff to our clients and from our clients to the pharmacists. So basic screening actually helps. And even talking to our customers when they come in, so that we reduce transmission of the infection. Then public educator is one of the roles of the community pharmacists. So we talk about hand washing technique to prevent transmission, use of sanitizers, which are of good quality and which actually are effective. A case which comes to mind is the Zambian pharmacists have been featuring on a CPA video, that is the Commonwealth Pharmaceutical Association. There's a video which was produced, which involved the Zambian pharmacists with the UK pharmacists in the preparation of sanitizers. And there was also one from South Africa, from Rhodes University, where they're also talking about production of sanitizers, which are of good quality, which are effective. Face masks, they've been said to be good for preventing transmission of the infection. But what we have noticed is that a lot of people, they often wear them upside down, or they don't even know how to put them and dispose of used sanitizers. And we have seen from Ghana they've got the video on that. In Zimbabwe, we also have the RPA, or Retail Pharmacists Association. They've produced a video, which at the moment is in Shona, which is one of the local languages. And they will be producing more videos for the other local languages to help people on proper use of the masks. And it's actually published on YouTube. Then the quality of the products. When there was the outbreak, there were a lot of products on the market. And obviously when there's an outbreak, the chances of counterfeits or substandard products becomes an issue. It could be the pharmaceuticals, the masks themselves, and sanitizers. In Zimbabwe, we've actually been liaising with the regulator because some of the masks did not seem to be of good standard. And the sanitizers, there's been stories or cases in various countries. South Africa, there have been a poor quality which have been reported in media. Same with Zimbabwe. We've seen substandard products on the market. So it's important also to educate the public and us as pharmacists to actually help in the distribution of good quality products, including sanitizers, masks, and so on. Next slide, please. Next slide. Thank you. We've been talking about those preventive methods. And then when we come to medicines, pharmacists are medicine experts. And usually at FIP, we usually talk about whenever medicines are being discussed, pharmacists should be found at the table. We should not be left out in that, in coming up with the essential medicines to treat the cases. And this should be based on case management guidelines. And pharmacists should be involved in the formulation of these treatment guidelines so that we come up with the correct products to ensure that they are available. Because if the policymakers come up with these policies and pharmacists are not at the table, the quality of the products, availability, and even affordability and access can actually become a challenge. So pharmacists should be involved in there. And as been mentioned earlier on from one of the presentations from Mauritius, if I pick a leaf from them, the pharmacists were not stated straight away as essential services, which is why they found that the police were sending them back. And Mauritius are not the only ones who were affected. I know we had a similar scenario here in Zimbabwe. So as RPA, Retail Pharmacists Association, we had to come up with a documentation and encourage production of identity certificates, which will identify someone as a pharmacist so that they could actually go through, even though there was legislation. But you find that the public is usually well aware of the doctors and nurses, and as pharmacists were often left out. So the public, and even maybe the legislator sometimes does not include us. We're looking at the guidelines for Zimbabwe in terms of COVID. The people who came up with the treatment guidelines, I looked for pharmacists, they were nowhere to be found on that list. So they come up with these policies and we are sometimes left out. So it's important for collaboration between all stakeholders in the supply chain, manufacturers, distributors, the community pharmacist, the government, who is also the policymaker, such as Health Ministry. For us here, we have Industry and Commerce, who is involved in the industry, and the regulator. They should all be involved to ensure that we have available medicines which are affordable and they're accessible and they're of good quality. So the pharmacists, so it is important for our associations to be part and parcel of the policy production or creation of policies which relate to medicine use and the whole healthcare process. Next slide, please. Next slide. Challenges faced by pharmacists. And I think from the presentations we've just received from the African pharmacists from the different countries, usually there's an information gap. In this scenario, in Zimbabwe, the Retail Pharmacists Association invited the Ministry of Health representatives to explain on the plan of action and disaster preparedness when the outbreak was announced. Because usually you find people are talking about it, and especially in the private sector, you might be left out, and yet you have got a very important role to play. And then you find that quite often the pharmacists are not recognized and often left out of the planning meetings, hence the need for continuous engagement and lobbying. And the associations have a big role to play in lobbying with government and other policymakers. Then we had the lockdown, which was another challenge. It resulted in customer flow being reduced, but that should not stop us serving the clients. So innovative processes were important. So we had to come up with the innovation, which include use of social media and apps, and use of the telephone or telemedicine, and then come up with delivery services so that our patients do not default. This would actually improve the service to our clients and all those who need pharmacy services. So in some cases, people would use Facebook, or even when you use your WhatsApp platform, and people look at our status updates on our platforms, and you can actually sort of advertise. But in terms of advertising and even the delivery services, we have to deal with that in terms of our legislation, and also our legislator to be involved so that we don't find ourselves, when we advertise, as being labeled as breaking professional conduct regulations, which relate to touting and so on. Then the direct impact or direct economic impact on community pharmacies is something to do with the costs themselves. So the cost of screening equipment, like infrared thermometers for the pharmacy or for the institution, have to be borne by the pharmacy. None were distributed from government, so the community pharmacy had to carry the cost or to bear the cost of screening equipment. Also the cost of masks for the staff and protective clothing, there was no free issue. Then the cost of sanitizers for all the customers who enter the pharmacy, and cost of disinfectants for regularly disinfecting the premises. And in some instances, the pharmacies have introduced screens or shields in the front of their, so that there's a barrier which is transparent between the pharmacist and the customer, and the pharmacist had to bear that cost. So the COVID pandemic itself, there are direct costs which increased on how the pharmacy business is run. But as pharmacists, we've had to bear those costs so that we ensure that we provide adequate pharmaceutical care for our clients. We did not increase costs of service of our products, but we did have the costs increased on the running of the business. Next slide, please. So support needed in conclusion. So we need to have a continuous pharmacy education. These webinars actually help, and we also share and hear what is happening in other countries. So FIP has actually been doing a lot of these webinars to make sure that we keep up to date with what is going on. And we also have the WHO website so that you can keep up to date with what is going on. It's also important to be involved in research, which is practice-based, and pharmacy education is also important, which looks also, we also need to look at the regulatory framework in terms of the kind of research so that we improve the quality of service. And in terms of implementation, we should look at what works according to our resource base. We need to also lobby with policymakers and get more involved as pharmacists. So our associations should do much more, especially in this pandemic, so that we also know how to work in cases of emergency. COVID pandemic has been an emergency, and most of us were not prepared to handle that. We also need to collaborate with other partners, multi-sectoral and multidisciplinary, in terms of all the sectors in pharmacy. When I look at pharmacy, we have the supply chain, which involves the manufacturers, the distributors, the community pharmacists, and our patients. We should never overlook our patients. They are an important and an integral part of our supply chain. And then also multidisciplinary in terms of the other professionals. Then we should also need to strengthen the professional associations. As an association or as associations, we actually can do better, and we can speak with one voice, and we learn from one another. So we need to strengthen the professional associations, and our participation as pharmacists should actually increase and come up with ideas and help those who are in office, so that we work together for the betterment of our profession. Together we can do better. Next slide, please. Prevention is cheaper than treatment. Stay well and keep safe. Let's all join our associations. Thank you.
Thanks, Jocelyn. Thank you very much. That brings us to the end of our organized speakers. We have 15 minutes left of this webinar, and I've already got a list of 26 questions that have been posed in the Q&A boxes. Now, the way I'm going to do it is I will try and bring in some of those questions in the questions that I posed to particular members of the panel. So I'm going to start by thinking about how regulation and pharmacy practice has had to change and be flexible in the way that it responds. So I want to put this question to Khatija. One of the responses around the world has been to create new field hospitals. Khatija, how are we manning, or let's make it a gender-friendly term, how are we provisioning the human resources for pharmacy in these field hospitals, which might have hundreds of beds? And how are we dealing with the regulatory side of having a licensed pharmacy in a field hospital? Let's keep these brief. Thanks, Khadija.
Okay, so in South Africa, from a regulatory perspective, for the premises of the pharmacy, it's considered to be a satellite, if you will, of an existing facility. So we didn't see the need. Oh, sorry. Apologies. I thought I had switched on the video. Okay, so we didn't see the need we had consulted our colleagues in the regulatory space on this, but because of the responsiveness that is needed, the licensing of facilities, often it's a protracted process, and we wanted to bypass that. And we felt that because it was a temporary nature of the facility being the field hospital, we would rather see them as a satellite of an existing facility. So they don't need specifically a registration as a pharmacy premises.
And the human resources, where are the pharmacists going to come from for a brand new 400 or 500 bed hospital? Yes,
so we were just discussing that amongst the colleagues today, incidentally. And it goes to what I say, we're going to have to stretch the available resources. There are no new pharmacists that's suddenly going to pop up. And it just means that, people may have to work longer hours, work in shifts, etc. We are trying to decongest the facility so that, the pharmacists are not as needed as they would have been on a normal non-COVID day. So hopefully we will be able to create more efficiencies in that the patients will not necessarily, given that we are going to multi-month dispensing for many of the patients, not necessarily require the services, to the extent that we think, given the intervention that we have implemented. So with multi-month dispensing, the expectation is There will be fewer patients coming to the facility for repeat medicines, which then frees up some time for some of the pharmacists to actually assist in the field hospitals. Also in the field hospitals, because there's no outpatients, and the basket of medicines used for high care and ICU care is very controlled. So that also has potential for creating efficiencies in how we use our pharmacy services in those areas.
Thanks, Khatija. Let me throw the next one at Jean-Baptiste. We see very different treatment protocols in different parts of Africa. What is WHO doing to try and ensure that evidence-based treatment is done everywhere? Secondly, what is happening with chloroquine and the Solidarity trial? And lastly, what is the approach from WHO to herbal preparations which might be proposed for the treatment of COVID-19 in African countries? Jean-Baptiste?
Okay, thank you very much. Maybe I will start with the chloroquine. As you know, chloroquine was part of the WHO Solidarity trial, but has been dropped from the Solidarity trial because of lack of effectiveness. So this is the main reason why it's dropped from the Solidarity trial. This is the current situation. For herbal medicines, as you know, WHO welcome all the treatment potential in particularly from traditional medicines. But before claiming or using those products for treatment, they need to follow the research protocols. They need to be tested in terms of preclinical and clinical tests. This is what we are doing now with Madagascar. We are developing a comprehensive clinical trial protocol, and we are also mobilizing expertise in our region to support Madagascar for the trial. How to harmonize case management or protocols in all the countries? We recognize that at the beginning of the pandemic in our region, countries take separately some decision in terms of adopting a protocol based on the capacity in place in terms of clinical management. But we are working with countries we have the guidelines, and we are supporting countries with the training for them to use the same or harmonized protocol in treating patients. This is critical to avoid many discrepancies in treating patients, and also in using medicine that are not relevant. For instance, we are now pushing for the use of dexamethasone because it's proven that it's bringing something very strong in terms of life-saving for patients. And WHO is working with manufacturers to increase the manufacturing and also the procurement to the African region. Thank you very much.
Thanks, Jean-Baptiste. Those of you who are looking at the screen will see a couple of names there from ICPA who haven't spoken yet. So I'm going to throw one at Jackie Mayman. We saw mention there of different ways of testing. Is pharmacy a place where COVID-19 testing can be done? And what's the approach in South Africa to that?
Okay, so up until now, we have not been doing the PCR testing. And in South Africa, as you know, the rapid diagnostics have not been approved by our regulatory authority. But what pharmacy has been doing is, as in some of the other countries, we've been doing a lot of the temperature scanning. We've been assisting, as our lockdown has been relaxed and companies have been going back to work, pharmacies have been very involved with assisting companies with their risk assessment of their employees, symptom screening. And what I can say, which is very exciting, is that as community pharmacy, we are now looking at assisting the government as we are experiencing our surge with the testing of healthcare professionals. And what we're planning on doing there is working together with the path labs to set up mobile testing stations so that we can go to the hotspot areas and test healthcare professionals so we can get them back to work as quickly as possible when they test negative. The other thing that we are doing is, well, waiting for are the rapid diagnostics. And I think we can make a big difference once that's been approved.
Thanks, Jackie. So I'm going to throw one at Daniela because we are running out of time. But Daniela, how are we going to prevent unregulated sales of dexamethasone or other corticosteroids and their use inappropriately in patients who are either not yet infected or have mild cases of COVID-19 and are being treated at home?
Just go again, Andy.
So how are we going to prevent inappropriate use of dexamethasone? What would your approach be in Kenya on regulating access?
Yes, this is a big challenge because as in many parts of Africa, we have the regulated outlets and we are far outstripped by the unregulated drug shops. And so one of the ways that we can really control this is at the distributor wholesaler level, which is mostly manned by registered pharmacists. And, you know, so stricter regulation on these wholesalers not to sell the dexamethasone to the drug shops, because that's where a lot of our patients, you know, our clients run to when they know they need to get across-the-counter medicine unlawfully. And so the other method would be just risk communication, a lot of public education and posters and just telling them this is for critically ill patients, it will not help you, you know, just with your little sniffle and cough. And so we can't educate people enough. And I really like the example from Ghana where they're doing it in many different languages. That's what will help.
Thanks very much, Daniela. Naveen, you've had very small numbers of cases, but I know that you've got a previous exposure to pharmacovigilance. How have you ensured that people are able to report any adverse events that they have, or if they are having problems with their current chronic medication, how is it that you are helping them adhere to that chronic medication?
Okay, so in Mauritius, we generally have a National Pharmacovigilance Committee. And for that committee, there are some reporting forms which are available at the hospital, hospital setups. So in case anybody, even the doctors working private and the pharmacists have those forms. So in case we did identify a few cases, or those people who are reporting it would pick up the cases, and then the pharmacists or the nursing officers or the doctors, whoever were at work and they got hold of it, they would email it to the committee so that they could track on it.
Thanks very much, Naveen. Ben,
welcome.
You mentioned testing in Ghana. Is that testing being done with PCR, or what are the other methods that are being used to test for COVID in Ghana?
Thank you. And currently is PCR that is being used for testing, but it's very decentralized. I mean, across the country from the northern to the south and east and west, so that there are not much delays in transportation of samples, and the drone system is also being used to deliver samples to these sites.
Thanks very much. Sham, are we missing the opportunity to really leverage the private sector in our response in Africa?
I think to a certain extent you've heard from across Africa, from many of the pharmacists, the issue of recognition the issue of the critical role that we've been playing. And I think the fact that even in South Africa, the first couple of weeks, the country was on lockdown mode. A lot of the doctors were not in their practices. And really pharmacy took the lead, especially in the private sector, to try and assist both government and the doctors' rooms in terms of managing patients during that time. So I think there definitely needs to be more emphasis, and there's some suggestions that we need to have a closer working relationship with government. And fortunately, through this COVID period, through ICPA, we've been lucky that we were at the table right from the beginning, working together with Khatija and regulatory issues, for example, putting out the different policies that was required in the country, whether it's for private or public sector, and assisting with some of the other regulatory issues. So just in terms of, I think that there could be a bigger role, and maybe Khatija is listening to this, we could assist, for example, at the tented structures at the moment. There are pharmacies that are going to be around those structures. We could do a service related to that. And I think there needs to be much more pressure from the associations on government for one, recognition, and two, for a greater role of the pharmacist in any type of management of pharmaceutical services in the country.
Thank you, Sham. Now, when you hit the time limit and you've got 35 questions sitting there, I would love to be able to go through each of them. I want to end with a couple of remarks from myself, and I'll give Jocelyn one sentence so she can start planning that sentence before we close. I think one of the key things that pharmacists can do is to provide evidence-based advice to our patients. So is there evidence for a higher dose of ascorbic acid, high dose zinc, high dose selenium, or other dosage ways of administering apart from oral? No, there isn't. Is there anything else that we know that works and can prevent mortality apart from dexamethasone? Not at the moment. But pharmacists can keep abreast of all of those changes and really make a difference in informing the public, getting engaged with government, making sure that the guidelines are updated and practical, and that we can deliver them for the good of our patients. So Jocelyn, I liked your last bit about professional associations. One sentence about what pharmacists can do in Africa that'll make a big difference.
Andy, as pharmacists, we are sometimes left out because we are not working together as professionals. We should be together in our countries and then even as Africa as a whole, so that we can lobby with governments in our base and then the international scene. So all together we can make it as pharmacists and be there at the table whenever medicines are being mentioned. Thank you.
Thank you very much, Jocelyn. This has been an incredibly powerful experience of cross-African sharing. I think you heard across all of those presentations far more that was common than what divided us. We were all in the same boat. I want to thank all of our speakers this evening. On that table in front of you, you'll see a number of names apart from Barbara who've been behind the scenes. Shivani, Donovan, been moving the slides along. Thank you for the help from AstraZeneca. And good evening from all of us. Stay safe, stay engaged. This is something that we can beat. Thank you very much. Good night, everyone.
Thank you, Andy.
Thank you.
Thank you very much. Good night. Bye-bye.
Jean-Baptiste.
Bye-bye, everyone.
Thank you. Bye-bye.
Thanks. Bye.
Thank you, everyone. Bye.
Thank you.
Take care.
Bye.